Hey guys, Gretchen Zablocki here for your Wellness Wednesday. So today we're at the Harris Clinic with Dr. Harris, and we just want to talk to you a little bit today about pain management, what pain clinics are, and then what some of your options are these days as far as regards to managing your pain and maybe some different options and maybe getting away some of the stereotypes of pain clinics. So Dr. Harris, you're a pain specialist, and how might that differ from a typical pain clinic?
Well, that's a good question, and thanks for letting me be here today.
Yeah.
It's a great question to start with. Unfortunately, there's a lot of misinformation about pain specialists and confusion in the medical community as well as in patients because of all of the pain clinics that sprang up around the country.
Yeah.
And particularly East Tennessee was one of the worst areas. The state of Tennessee about 5 years ago had approximately 340 pain clinics. Now they have about 100.
Okay.
And so now you have to be board certified, and the state recognizes 3 different board certifications to allow you to be in charge of a pain program. I don't like the term pain clinic, and
Right.
we're not registered as a pain clinic. But I'm a board certified pain specialist, and that's someone who studies the field of what causes pain, how does it affect you, and how can that be treated.
Okay. So what kind of certifications or specialties did you have to get certified as a pain specialist?
Well, the state again recognizes 3. I have 2 of those. American Board of Pain Medicine, which is a big organization. You have to have years of experience, and then you have to take a test. And I think the gold standard is the American Board of Medical Specialties, which grants cardiologists, anesthesiologists, general surgeons. They certify all of those main fields of medicine.
Okay.
Anesthesiology was the first main field to have a subspecialty of pain medicine. That was
Okay.
started in 1993. And I received my certification in 1994.
Okay.
And I've had to test every 10 years, so in 2004, 2014. So it required, now you absolutely have to have a fellowship specifically in
Okay.
that. There weren't many when I went through, but I had at that time 8 years of experience, and I was running a large pain program in Knoxville and doing a lot of high-end procedures. So I qualified and passed the examination, so I have basically the fellowship level certification.
Okay. And how would you say a patient's experience would differ here versus just a typical pain clinic?
Well, the way we approach a patient, what we try to do is find out what exactly is the diagnosis, what should it be?
Right.
And people come to us with back pain, for instance. That's not really a diagnosis. There's something causing that pain. It could
Exactly.
be any of a number of things. You know, I was in medical school, we joked about the low back pain being a black box. We don't know what's in there. But that's not really true anymore. With some of the selective techniques we have, we can pinpoint the pain generator in about 7 or 8 out of 10 cases.
Okay.
A regular pain clinic would just see somebody, my back hurts, they would put them on medicine for it.
Yeah.
Okay, and so we don't go that route. We spend a lot of time trying to make an accurate diagnosis, and then we also look at the patient as a whole, an integrative approach, looking at their emotional factors, psychological factors, financial, family factors, other health issues they have. All of these things can affect their pain, and their pain can affect all these other areas of their life.
Right.
And we want to make sure their breathing is good, their functional ability to get in and out of the house and out of a chair safely, so we evaluate all of that. And then we get down to formulating a treatment plan.
Okay.
So we don't just see someone, put them on medicine. That's
Right.
not what we do or not what we want to do.
Yeah. And so holistic is a big word that's out these days, of holistic medicine. And so that's really what you're taking, is more of a holistic approach, the whole person.
I think it has to be that way.
That's
And I
great.
think all of medicine is going that way because we're not isolated problems.
Right.
When you take someone who has a severe chronic pain problem, whether that's a bad knee and they can't work, or bad back or neck, or a work injury, their whole life has changed.
Exactly.
They have emotional issues that maybe are worse or that they didn't even have in the past. They have financial issues. They can have social issues. Divorce, very high among people with
Yeah.
years of chronic pain. So you have to look at the entire patient, the family, their surroundings. Sometimes, their living conditions aren't good.
Yeah.
So we really try to look at all that, and we try to look at them from a functional standpoint, make sure they're safe.
Yeah.
You have to look at it that way.
Well, and I know these days with the opioid epidemic and all of that, a lot of our regular primary care doctors are scared to write pain meds. And so you get a lot of referrals from that with you trying to manage that. And so do you have any thoughts on that, a different approach, how we might deal with that?
Well, that's one of the most pressing problems right now. The state of Tennessee and the federal government several years ago decided that this was a problem that was just getting out of hand, and they were right. And so I said that we went from 300 and something pain clinics down to 100, and a lot of pressure was put on, a lot of regulations and guidelines have been issued, and physicians have become afraid. It's one thing you can do to really get in trouble when you think you've done it right. But I do have some thoughts about that. First of all, we only have 100 or so board-certified pain specialists in the whole state. I'm the only person between Knoxville and the Tri-Cities with that certification. There's no way that we can write all the pain medicine for everybody that's out there on pain medicine right now.
Right.
Now, some of those people may or may not need to be on pain medicine in the future. There may be people out there that don't have it that need to be on it.
Right.
The state of Tennessee has been very clear about saying that a lot of the writing of these medications should fall into the hands of the primary care provider.
Okay.
But the thing that I want to say about that is where we are at our best and where we can help the most is in the things I just described.
Yeah.
Finding the accurate diagnosis, seeing if there's one little thing we can do, if we can find the source of the back pain, or sometimes like after a total knee, a patient can have pain on one side of their knee. It may be a single nerve that's been cut. The infrapatellar branch of the saphenous is a common cause of pain there. Mm-hmm. People can have it 10 years, and everyone say nothing can be done.
Yeah.
Well, you can actually sever that nerve, or you can stimulate that nerve.
Yeah.
So we have options for things that other people haven't thought about, and it's our job to know what other techniques should be considered, what the diagnostic workup for each particular problem should be, what things we might be able to look for if it's a shoulder or a knee or a back or a neck, that we might be able to find something to give us an edge and a chance toward treating it and reducing the opioid use. But it is difficult. The primary care physicians are going to have some time to become more comfortable.
Yeah. And
it is an issue because we cannot, it would be impossible for me. We get 150 referrals a month.
Yeah.
We evaluate the vast majority of those, but we send almost all those back with recommendations at this point, because there's no other way that we can do it. It's impossible.
Yeah. I know we're going to be back with you in a couple weeks to talk more about different specific options that you offer here, maybe some treatment plans and things like that. But is there anything else that you want people to know today just about your clinic, how things are different? Are you accepting new patients? Does someone have to have a referral? How does that work?
Sure. We are accepting new patients.
Okay.
We have to have a referral only if insurance requires it or if it is strictly for medical management. But we do not ever accept a patient just to write the medications. We accept them for evaluation only.
Okay.
And so when they're referred for that, they go through the same process everyone else does.
Yeah.
Let me say one other thing. We do have a lot of interesting new things that a lot of patients don't know anything about, and some physicians are unaware of, that can help with chronic pain. But when we were talking on the last item about the referral of patients on opioids, I'd like to make a very complicated issue maybe somewhat a little more simple.
Okay.
I put people in 4 categories. The first category is a patient that's non-compliant. They're not doing what they're supposed to do. the doctor can tell they're not taking their medication correctly, they're making no effort to do the right thing.
Yeah.
That's not an appropriate referral.
Right.
That's not an appropriate patient to even be treating with opioid medications. It's a controlled substance. If the doctor doesn't have control, you should stop.
Right.
The second is a group of people that are legitimate patients that maybe the doctor feels like they're on too high of a dose. That's a perfect referral for us to look at them and see, can anything else be done?
Yeah.
Or if the patient says, I can't come down on my medicine, maybe we can find some ways to help that pain a little bit. Or maybe we can come up with mixing their medications in a way to allow some of those opioid doses to slowly come down over a period of months.
Yeah.
So we can help there. A patient who's on all the rest of these are legitimate patients, which most of the people in East Tennessee are actually.
Yeah.
Legitimate patient who's on an average amount of medicine, regardless of what the state guideline is for referral. My opinion, if they have chronic pain and they're on opioids, they need a referral. We need to know the state does require that before you start opioids or continue opioids, that you know that everything has been checked, it could be checked, and every other option has been pursued.
Yeah.
And so if a primary care doctor is just treating somebody for 8 years because their back hurts, they really haven't gone through the whole process. When I saw a surgeon, he said no surgery. Well, that's really not trying to get at the things that you can get at, because the surgeons have their place and we have ours, and ours is try to find that pain and reduce it, to reduce the opioid dose. And the fourth category of patients is, I think, the most important in a lot of ways, because it's the people we don't ever see, and the ones that we really should see, and that's the people that come in that have pain, or maybe have not even seen a doctor yet. They don't really want to go on opioids. They're not on opioids. Maybe they do. Maybe they think, do I need to be on a pain medicine?
Yeah.
We should see that patient, because we may find something to keep them from going on opioids in the first place.
Yeah.
And the studies that look at people with a chronic pain problem who take opioids for 2 weeks, they're very likely to be on it a year later. If you look at the same kind of person with the same kind of pain problem that doesn't take that 2 weeks of opioids, they're probably not going to be on pain medicine a year or 5 years later.
Yeah.
So that first decision that's made to put a patient on opioids is a huge decision.
Yes.
And we should be involved in that.
Yeah.
And so that's the group that really, any of those last three groups, the people that the doctor's worried or the patient's worried, am I taking too much to have sleep apnea? Absolutely. We need to see that patient. We're probably not going to manage it unless it's really extreme and it needs to be subspecialty managed. But we're going to try to get the dose down or manage that patient better. The next group that's on pretty normal dose, but maybe we can do something better.
Yeah.
And then again, the group of people that are having pain but just haven't wanted to be on pain medicine or whatever, please let us see them first before they get started.
Yeah.
That's the message I would get out there.
So I don't know about you guys, but it's super exciting for me just to hear about this service that we have here in Morristown. And probably a lot of you guys didn't even realize that the Harris Clinic was here, or even exactly what they did. But I think it's great that we here in Morristown and the surrounding area have Dr. Harris here to take that holistic approach to pain, because I know so many of us deal with chronic pain. And so if you are in a situation of chronic pain and you're going, I don't want to be on opioids, or I want to reduce them, or are there other options, please get with your primary care doctor and ask for a referral to come see Dr. Harris, or give a call to your insurance and see if you even need a referral. But as I said, we'll be back with Dr. Harris in a couple weeks to talk more specific about different options and treatments and things like that. So join us for that. We hope you have a great Wellness Wednesday. Dr. Harris, we thank you so much for your information.